Welcome back, everybody. It's Jason Williams again, and I'd like to welcome you back to our hospital medicine point-of-care ultrasound volume status curriculum. Again, this is a course tailored towards hospital medicine patients in our routine clinical practice, and you can find the entire curriculum, both for volume status and other organ systems, at my website, proceduralist.org. Let's review kind of where we've been and where we're headed. So hopefully you've already viewed part 1, 2, and 3 of this curriculum, including how to look at the inferior vena cava and apply that to volume status and congestive heart failure patients. We just looked at how to use the jugular vein for volume status assessment. And now in part 4, we're going to go through some more case-based scenarios of applying these concepts, particularly to hyponatremia, ascites, leg edema, and acute kidney injury. And last but not least, in the next part 5, we'll go over shock, which deserves a whole lesson in and of itself. So let's dive into part 4 for volume status ultrasound cases. I really want you to recognize common inpatient applications for volume status assessment and also give you a framework or an algorithm to incorporate point-of-care ultrasound into your decision making. So without further ado, let's dive on in. So the take home from this case is really all patients on diuretics should get a POCUS exam. Even if they're not complaining of volume status issues, I think it's important to routinely check in on patients on diuretics to see what their volume status is. Here's one patient who was a 91-year-old male with a history of heart failure with preserved ejection fraction, SIADH, and CKD. All of these are chronic issues. He came in for a fall and was just waiting for placement. He had been on Lasix for about 2 years, and during his hospital stay, it was noted his sodium kind of downtrended from 121 to 117, so we decided to assess his volume status and see where he's at. He had no real active medical problems, but I think it's important to check in on these patients' volume status. He's on a diuretic with potential complications. So when we did a lung ultrasound, there was no B lines present, and he had no leg edema, so those peripheral or extravascular compartments had no signs of fluid. When we look at his inferior vena cava, it's hard to find. Some people refer to this IVC as a sliver in the liver because it's 100% collapsed. This is as empty as the IVC is ever going to get. There's not much dynamic collapsibility because it's 100% collapsed throughout the entire respiratory cycle. This is a person with a very low central venous pressure. Again, if you're having trouble finding the inferior vena cava and you have plenty of liver, it may be that the IVC is 100% collapsed. And that's where I really focus on the right atrium to see where a break in the diaphragm leads to this small sliver in the liver IVC. So this patient has dry lungs, no leg edema, and a very low central venous pressure. We decided to stop his Lasix, and his sodium uptrended to a normal range slowly over several days, and his creatinine normalized. So this wasn't a patient with SIADH and CKD. He was a hypovolemic hyponatremia patient, and he had pre-renal AKI, all as a side effect of his diuretic. No one had checked his volume status for, days, weeks, months, or years, realizing that his diuretic was causing these other comorbidities. And with a good volume status exam, point-of-care ultrasound can clue you into this early. Let's go over another common scenario. Someone coming in with abdominal swelling and shortness of breath. So this is your classic 53-year-old with alcohol-related cirrhosis. He reported a 20-pound weight gain, no leg edema, and his lungs were clear to auscultation. He had an obese abdomen, but it was thought that there was likely ascites on exam by the overnight resident. And the working diagnosis that was presented to me the next morning, this patient just has tense ascites. He needs a therapeutic para that will get rid of his abdominal swelling, and that's what's causing a shortness of breath. The diaphragm is probably pushing up into the thoracic cavity because of all that ascites buildup below it. So he had some ascites, but while we were looking at his ascites, I always recommend looking at the inferior vena cava in anyone that has ascites. So here's this patient's in IVC, much different than the last case. There's really minimal collapse, and the maximum diameter is about 2.93 centimeters. That's a dilated inferior vena cava with minimal collapse. And again, we know it's the IVC because we see the hepatic vein very clearly here. It enters the right atrium. So this patient's central venous pressure is pretty high. It's a CVP of 15 millimeters of mercury. He's intravascularly volume overloaded in terms of his right atrial pressure. That's very unusual for patients that are traditional cirrhotics that have portal hypertension. So what I recommend, anyone that has ascites, it's good to look at their ascites with ultrasound, but go check out their inferior vena cava. Most patients will have a CVP that's not overloaded, but if you see a CVP over 10 millimeters of mercury, you have to start thinking about cardiac ascites. So for instance, this patient, when we did his paracentesis, here's his serum ascites albumin gradient was over 1.1. That just tells you there's high portal pressures. It doesn't tell you if that portal pressure is coming from obstruction from the liver due to cirrhosis, or if it's coming from high pressures from the inferior vena cava backing up into the hepatic vein into the portal system. So when we look at his IVC, we know his CVP is high. So then I recommend looking at the heart. You may be missing cardiac ascites and heart failure. If you see signs of left ventricular dysfunction, there's a chance that fluid could also be backing up in the lungs, and that could be causing pulmonary edema. So lung ultrasound can help solidify this diagnosis. So our patient, he had a very high central venous pressure, and we looked at his heart. He had severe right heart dysfunction. So we ended up giving him IV diuresis over about a week or so. He had a 20-pound weight loss, really massive weight loss via IV diuresis. And he was given a new diagnosis of portal pulmonary hypertension, and he's currently being followed by the liver transplant clinic for potential liver transplant in the future. So distinguishing cardiac ascites from traditional cirrhotic etiologies, I think it's important, and there's impact in terms of management in these patients. So how do we figure this out? Well, peripheral edema, particularly leg edema, can be present with cardiac ascites, but also with cirrhosis. Oftentimes the albumin are very low, and these patients may have anasarca in the setting of cirrhosis that's not driven by high inferior vena cava pressures. Pulmonary edema is more commonly associated with left heart dysfunction. Again, if there's truly a low albumin state, you may get a few B lines in the lungs, though, due to anasarca. But the real big distinguishing feature is going to be central venous pressure, either IVC or JVP ultrasound, and you're going to have high central venous or high right atrial pressures, unlike a patient with cirrhosis. If you recall, the IVC is in the abdomen, and if you have a ton of ascites in the abdomen, it's usually squishing the IVC. It's very rare to have a dilated IVC, A, because ascites is extrinsically compressing the inferior vena cava, and 2, patients tend to have very low intravascular volume status, both effective arterial volume and central venous pressure, due to their low oncotic state. Patients with cirrhosis tend to have very low albumin, which means they have less fluid in their arteries and veins. So for multiple reasons, most cirrhotics have a small collapsible IVC due to low oncotic state and extrinsic compression from ascites. So if you ever see an IVC in this case that's distended and not collapsible, you need to immediately think of cardiac ascites, because the management is different. Patients with a cardiac ascites tolerate IV diuresis much better compared to patients with cirrhosis. Because patients with cirrhosis have low oncotic pressure, you tend to reduce their effective arterial volume with IV diuresis, and they go into pre-renal AKI very quickly. So to manage patients with cirrhosis, paracentesis is the most effective modality. To manage patients with cardiac ascites, IV diuresis is very effective. And so figuring out who has cardiac ascites versus who has cirrhosis, it changes the way you manage their volume status. All right, so let's go through another clinical scenario. This is a 90-year-old male with hypertension, diabetes, and CKD. He comes in with left leg swelling. He notes swelling, pain, redness for about the last week or so. He's afebrile on exam, and the resident from the night before notes that he has jugular venous distension to the sternocleidomastoid. I'm not exactly sure what that means. You'll remember the jugular vein runs underneath the sternocleidomastoid, and so it doesn't quite make sense. Maybe they were saying jugular venous distension to the mandible. It's hard to interpret, but I think they were trying to say that they thought they had high central venous pressure on exam. This patient had 2+ leg edema on the left, 1+ on the right, and this redness and swelling was noted. But then there's a confounding factor. The patient's BNP is also elevated. The chest x-ray is read as mild pulmonary vascular engorgement, and maybe there's a little bit of cephalization of the vessels, but there's no overt pulmonary edema. Overall, these lungs look pretty clear. So we have some data points kind of going back and forth in terms of the volume status of this patient. The BNP is up and there's leg swelling, but it's asymmetric. There may or may not be jugular venous distension. It's hard to tell. So the plan overnight was like, let's give some IV Lasix because we think there's a CHF component to the leg swelling. Let's also give some antibiotics because the thought is there's a cellulitis causing pain and redness and the asymmetry in the leg edema. So I think ultrasound is very, very, very helpful in patients with leg swelling to clarify several etiologies. So when we did our POCUS exam, I usually start the legs. Let's first rule out DVT or obstruction of the leg veins. In this case, there was no DVT causing that asymmetric swelling. And then I'll go up from the legs to the IVC and see, is it driven by high central venous pressure, this leg edema? And here you can see the IVC max is 1.8 centimeters. The collapsibility is about 20%. So what is this patient's central venous pressure? This is one of those tough ones where his IVC is small, but he has poor collapsibility, less than 50%. So he technically ends up in this middle category with a central venous pressure around 8 millimeters of mercury, which is normal. But you'll recall from part 1 of this lecture, this is the least specific category. So it's only 28% specific. In other words, 80% of the time, the CVP is not at 5 to 10. It's either lower or higher. And we really need to figure out, does this patient have high central venous pressure, and should we continue IV Lasix because there's a CHF component? I'm thinking less likely at CHF. He only has one B line in his anterior and lateral lung zones, which is minimal to no significant pulmonary edema. And his heart looks totally normal. The EF is normal. There's no right heart strain, no pericardial effusion. So how do we sort out this central venous pressure when we're in this middle mixed category? This is a great time to do jugular venous pressure ultrasound. So here's this patient, and we place the ultrasound in a transverse plane just above the clavicle. And here's what we saw. You can see the carotid here, and occasionally you can see the jugular vein. And it's got some pulsatility to it. Those are the A and V wave pulsations we talked about in the last section. So at the clavicle, you already have almost full collapse of the jugular vein. So we've found the collapsible point literally at the clavicle, which is about a centimeter below the sternal angle. So the way I would report this in my notes is I would say at a 45-degree angle, the JVP is 1 centimeter below the sternal angle. In other words, his central venous pressure is 4 centimeters of water, because if you subtract 1 from 5, the right atrium is approximately 5 centimeters below the sternal angle, and we find our jugular venous pressure 1 centimeter below that, so his central venous pressure is 4 centimeters of water, which is very normal. This does not look like CHF or high right atrial pressures driving this patient's lower extremity edema. So whenever I look at leg swelling, POCUS can really help in the algorithm. First, you start with the swollen leg and rule out DVT. If there's no signs of DVT, work your way up to the inferior vena cava. And if the central venous pressure is over 10 millimeters of mercury, look for CHF. The lung and heart ultrasound is an important component that can add to your CHF exam and solidify that diagnosis. That's when you would start more aggressive IV diuresis. In this case, the central venous pressure was normal. It was less than 10 millimeters of mercury. So he was diagnosed with more venous stasis, and we felt comfortable giving him compression stockings and leg elevation to help manage that venous stasis chronically. All right, I think this is our last case. So let's go over, this case is a 78-year-old male with obesity, OSA, dementia, heart failure with preserved ejection fraction, and chronic kidney disease. He came in with weakness and acute kidney injury. And initially he had an AKI. His baseline creatinine is 2, and he came in at 2.5. So the team stopped Lasix and gave him some fluids, and you can see his creatinine got better the first couple days with stopping his diuretics and giving him fluids. So maybe there was a pre-renal AKI component to this. Then his creatinine started to drift up a little bit, and so they're like, well, let's restart his home diuretic. After restarting the home diuretic, there was a big jump in creatinine. So they're like, oh, stop the Lasix. That was a bad move. Let's give him some fluids. But then they gave fluids, and his creatinine continued to escalate. And so at this point, I was asked to consult on the patient and do a point-of-care ultrasound assessment to help figure out what is going on with this patient's acute kidney injury. They thought he was pre-renal, then started some Lasix. Then we're like, oh no, he is pre-renal, give him some fluids. They treated pre-renal again, but it continues to get worse. And so ultrasound can add a lot to our acute kidney injury assessment and sorting out not only volume status, but potential obstructive etiologies as well. So when I examined him, he had very mild leg edema. I wondered if he had orthopnea. This patient had some dementia and had trouble following commands. He refused to lay down. He was sitting very upright, and I wondered if orthopnea contributed to his refusal to lay down flat. We did find urinary retention. On his point-of-care ultrasound, he had a lot of urine retained in his bladder, but when I looked at his kidneys, there was no hydro. So it's hard for me to believe that this is all explained by obstructive uropathy. If you have AKI due to obstructive uropathy, that should be translated up into the kidneys, and once you get hydronephrosis, then the creatinine will start to rise. This definitely needs to be addressed, but I don't think this is the full story given the lack of hydronephrosis. Something else may be driving this acute kidney injury. And then he was very obese, so we were only able to get good windows anteriorly on his chest, but he had 4 B lines anteriorly. So you can imagine if you went to the lateral and posterior lobes, you would see even more B lines. I had a suggestion with just an anterior assessment of his lungs. These were very wet lungs with a lot of B lines. And we really couldn't find his IVC due to his obesity and inability to lay flat. So this is a great time to use our jugular venous ultrasound exam. And so again, this patient's sitting upright at 90 degrees in a chair. And when this starts over, we start low at the clavicle right here. Look at this big IJ, and then we're going to slowly slide up. And you see the IJ is getting closer to the size of the carotid. As you slide a little bit more, here's this beautiful collapse point. We found the collapse point. So we start at the clavicle and slide up until we find the collapse point right here. And then we measure where we find that collapse point, which was about here. It was mid-neck. So here's his sternal angle. So we're about 1 centimeter or 2 over his clavicle. But in this case, because he's sitting upright, that is many centimeters away from his sternal angle. So in this case, we're about 6 centimeters above his sternal angle. So this is how I would report it. I'd say that at 90 degrees, this patient's JVP was found 6 centimeters above the sternal angle. 6 plus 5 would be a CVP of 11 centimeters of water. And we know as the centimeters get higher and higher like this, the specificity for CHF gets higher and higher. So once the CVP reaches 11 or 12, I feel very confident saying this patient has high central venous pressure, high right atrial pressure. He's got some pulmonary edema. This patient would benefit from IV diuresis. So going back to the diagnosis of cardiorenal AKI, again, I think about volume status in 4 different compartments. His peripheral edema or leg edema was pretty mild. It was just 1+. His pulmonary edema on lung ultrasound was at least moderate. Again, I like to do an anterior lateral lung zone and then add up the total number of B lines. You can refer to the lung ultrasound curriculum part 2 in terms of the specifics of the scoring system, but he had at least moderate pulmonary edema. His central venous pressure was quite high on his JVP ultrasound. And the big question was, what was his effective arterial volume? Did he have low arterial volume and then we gave fluids? And so in this case, I feel confident saying he's going to benefit from IV diuresis, and we should probably place a Foley to drain that urine at 500 cc's. And so he was diuresed aggressively for 5 days and had an awesome improvement in his creatinine. And he really did have a cardiorenal AKI that we felt much more confident diuresing given the high central venous pressure and the new pulmonary edema that was found on ultrasound. So let's review our POCUS exam for acute kidney injury. Anytime we start with AKI, I like to look for hydronephrosis, especially if you give fluids day 1, because prerenal AKI causes AKI 70% of the time. But if someone gets fluids and they're not getting better, that's usually when I'll put a probe on the patient and take a look at their kidneys. Again, for more about hydronephrosis exam, you can refer to our abdominal point-of-care ultrasound curriculum at proceduralist.org. In this case, this patient had no hydronephrosis. So then I like to look at central venous pressure. And if there's a very low central venous pressure, that's consistent with a prerenal AKI, and let's give those patients fluids. In this case, this central venous pressure was over 10 millimeters of mercury. We were concerned about cardiorenal, and that lung ultrasound was a nice slam dunk that confirmed, hey, he's got fluid in his lungs, high CVP. This is consistent with cardiorenal AKI. We started diuresis and really markedly improved his care overall. All right, that's the end of part 4 in our volume status ultrasound applications. You'll remember in part 2, I really think the highest yield for point of care ultrasound tends to be patients with shortness of breath and congestive heart failure in terms of the diagnosis and management, excluding things like COPD and looking for pneumonias. But the other common inpatient problems that we chronically encounter, I argue that anyone on diuretics should be getting a point of care ultrasound exam to check their volume status. Ultrasound is very helpful to clarify hyponatremia in terms of hypovolemic, euvolemic, or hypervolemic hyponatremia. The workup of ascites, it's impressive how much ascites is driven by the heart, in which the management is very different in terms of aggressive IV diuresis with cardiac ascites. With leg swelling, it's not just DVT, but you can also look at their central venous pressure and see if their IVC is driving that swelling in their legs. And finally, with acute kidney injury, in addition to looking at the kidneys themselves, establishing their volume status, pre-renal versus cardiorenal, can be very helpful in these cases. All right, that's the end of part 4. Thank you again for joining me. And you can find part 5 at our website, proceduralist.org, and you can review this and many other components at the website as well. So thank you very much. Take care.